My name is Alan Nord. I'm a primary care doctor in Rapid City, and I'm very proud to be one of the newest members of the Parkinson's Foundation board. Join me in welcoming our next speaker, Dr. Andrew Ritter. He's a movement He is a movement disorder specialist at Vera McKinnon here in Sioux Falls. He started in 2018. He's a graduate of the University of South Dakota School of Medicine, and then did a neurology residency and a movement disorder fellowship at the University of Michigan. He brings us expertise in the treatment of Parkinson's disease and also related diseases, and has done research in deep brain stimulation. So it's our honor to have him here today. His discussion will be recent advances in Parkinson's disease. Dr. Ritter.
Thank you. Thanks. Let's see. Is this the cue slide? Oh, there we go. Oh, I think that's pretty loud. Hi, everybody. I'm Dr. Ritter. It's nice to see you all this morning. It's a beautiful morning to be here. And today we're going to talk about kind of an update on Parkinson's disease therapies, really more than Parkinson's disease itself, I suppose. And then we'll be taking some questions kind of at the end. This is probably not a complete overview of everything related to treatment in Parkinson's disease, but it's a good kind of broad one. So first, a little bit of an overview. So we'll talk about some new drugs available, new ways to get drugs, a little bit of a DBS update, and then kind of some future directions, what we're looking at for other therapies and disease progression prevention in the future. So I'm sure we've all heard of levodopa, carbidopa, levodopa, Sinemet. It's also in Rytary, Stalevo. Levodopa is still the best option for most people. In Parkinson's disease, you don't make enough dopamine in a certain part of your brain, and you kind of use dopamine to calculate how much and how fast to move, kind of in a sense how much you want to move to get things done. So everything kind of slows down, and the tremor comes out because the movements are a little bit imbalanced. Carbidopa, levodopa, Sinemet, the levodopa becomes dopamine in the brain and basically replaces what you're not making. The levodopa, it's levodopa and not dopamine because it has to be levodopa to cross into the brain. There's a big barrier between your blood vessels and your brain, and the levodopa can cross that barrier where not a lot of other things can. The carbidopa basically helps it get there more efficiently. It prevents it from being broken down in your bloodstream and lets it be changed into dopamine in your brain. If it breaks down in your bloodstream and becomes dopamine in your bloodstream, it basically just makes you throw up. It's very, very nausea-inducing, and so the carbidopa helps out a lot with that. The movie Awakenings, Robin Williams, kind of 80s, great movie, but it was about levodopa, the development of giving people that had kind of infectious-related Parkinson's, like the last pandemic in 1919, caused a lot of encephalitis and swelling of the brain, and that caused some Parkinsonism, and he developed levodopa to help with that, and it woke people up who were very stiff before. So it helps the stiffness and slowness, it can help the gait sometimes, and it can help the tremor quite a bit too. Also, dopamine is involved in kind of mood too. Kind of when you win the lottery, if you do something really exciting, if you learn things, you kind of get a bit of a hit of dopamine in your brain. So it kind of makes you feel good. And so the dopamine from the medication also can kind of do that too. However, you can kind of cause some side effects as well. These are all basically dose-related side effects, meaning they happen when this is at like the peak dose in your body. And those are, if you've seen Michael J. Fox on TV at all in the last probably 5 or 6 years, he always kind of has these extra wiggly movements. Those are dyskinesias, and that's from kind of overloading dopamine cells a little bit. It can cause hallucinations. Sometimes it makes people sleepy. That nausea, even with the carbidopa, can still sometimes be there. Also, it can lower your blood pressure a bit, and usually that's great, but if it makes you lightheaded, we have to be a little more careful. And again, most of those side effects are related to kind of the peak dose, the peak bloodstream level of that medication. And when you take the pills, they kind of kick in and they wear off. There's this kind of up and down thing going on. And so smoothing that out is helpful for the symptom control. So that's the levodopa, I guess. So I'm going to start with the kind of new therapies, talking still about levodopa, one of the oldest therapies, because there's new ways to get it now. You take it by pill, it kicks in after somewhere between 15 minutes and an hour. It peaks after about an hour, 2 hours, and then starts to wear off. Because you take the pill at one specific time. If we can do it more continuously, it can get rid of those big fluctuations, get rid of some of the side effects of levodopa, and prevent some of the drop-offs. Because when it gets broken down, you don't have enough dopamine, all of a sudden the stiffness and the slowness comes back, the tremor comes back. Some of the mood can drop too. So if we get rid of those peaks and troughs, it can be quite helpful. So there are 2 pumps available, both by AbbVie. The newest one is called, I think they call it Vylev. It looks like Vyalev to me, but I think they call it Vylev. It's a phoscarbidopa, phos-levodopa. So they tweaked the medication a little bit because this one goes into your skin. So it doesn't go through your GI tract, your stomach or your intestine at all. It's just infused underneath your skin. I kind of compare it to a kind of an insulin pump almost. It's a little tiny pinprick of a thing, and there's that little sticker that you see there. Let's see, that little sticker that you see there has a tiny little plastic needle, and it goes into your skin. It gives you a constant rate of levodopa all day long. It doesn't go up and down. You can actually wear it overnight too. It's brand new. It's a little hard to get it covered right now, but I think it can be very, very helpful. You don't have to take pills. You don't have to watch the timing of the pills. So that's the brand new one. It is technically available, although somewhat difficult to acquire at the moment. That probably will change in the next 6 months. The other pump that is currently available and easier to get is called Duopa. It's just carbidopa levodopa, and it goes into your intestine. So they poke a hole through your stomach, put this tube that kind of goes into your intestine, and this little device here is a pump. This stuff down at the bottom, that's the medication, and the top of it is a little pump that kind of pushes it in through that tube into your stomach. The levodopa, even when you take it by mouth, actually gets absorbed past your stomach, kind of down in this first part of the intestine, and the tube goes right there, basically. So it puts the levodopa right where it needs to be, and is much less affected by food and GI motility. Because in Parkinson's, everything slows down, including how fast your stomach moves food through. There are times in Parkinson's where the pills kind of almost get stuck in your stomach. They don't move into the intestine where they need to get absorbed, and this pump kind of moves it past that. So again, it gives you a much smoother dose of levodopa for the course of the day. It does involve a hole in your stomach, and you have to take care of that a little more. But you can unhook the pump, you can go swimming with it, kind of cover it up. And these tubes are very common. Any GI doctor or a general surgeon can do them. I don't know, it takes 20, 30 minutes probably to do the procedure. And again, it's similar to that first pump in that it's a nice smooth dose. But there's just the downside of the incision. And so this is kind of, again, the goal of it. So again, this is your off times where the pills aren't quite working well enough. This middle area is your kind of on times, your good times, and the top part is when you have dyskinesias, or sometimes if you get lightheaded or have hallucinations, it can kind of happen in that time. And this graph, probably this little gray area of on time should be much wider here, especially early on in the disease. Your on times can be a lot better than that. But as the disease progresses, sometimes you break down the levodopa, not necessarily more efficiently, but you don't make as much of yourself, and so you need more pills to get it into that range of on times, and so it fluctuates more. And so things like these pumps can kind of smooth it out more like this. It's still, it's not perfectly smooth, but it's a lot smoother. So it kind of stays in that on time a lot more easily. So the negatives, obviously these pumps are something you have to kind of do something with. They are outside of your body. People kind of wear like a fanny pack, or there's like certain types of vests you can put them in. They're more expensive than levodopa. Cinemet's been around since the 60s. It's dirt cheap. And it doesn't have any more effect, more positive effect than the carbidopa levodopa. It just smooths out that effect. So you're not having the ups and downs, you're just having kind of the better good times. But if the medication, carbidopa levodopa, doesn't help things, sometimes it doesn't help the tremor, sometimes it doesn't help the gait, these won't do that either. They just can kind of help prevent some of the side effects. And then there is a new version of carbidopa levodopa 2. So there's the regular Cinemet, there's Cinemet ER or CR, continuous release, that lasts a little bit longer. There's medications like Rytari, which are the combination of a long and short-acting Cinemet, or carbidopa levodopa. That acts a little bit longer yet. There's Stalevo, which has another medication in it called entacapone that helps prevent the breakdown of levodopa, helps smooth it out. And now there's this new one called Crexont, which is kind of a specially made pill with a lot of different coverings on it, which you'll see here in a second, that helps it last even longer. So this is a chart actually comparing regular levodopa, the IR-CL or CD/LD at the gray chart there at the bottom. Let me see. That's regular Cinemet, this is Rytari, and this is that Crexont. This is probably from the Crexont website, but and so they do last longer. This is time in hours here at the bottom, so the peak and trough drops off quite a bit with regular levodopa after 3.5, 4 hours on average. Again, some people's lasts a lot longer than that, some people's it's shorter than that. And then the Rytari and Crexont last longer. However, you see the dosing here. This is 168 milligrams of levodopa. That's about a pill and a half of Cinemet. This is 540 milligrams of levodopa. So a lot more. And so really, when you move from regular Cinemet to Rytari, the milligrams of levodopa goes up by 60 or 70%. It's quite a bit more levodopa, actually. It's not quite as strong in that sense. But we can usually kind of get the equivalent dose, but it is not a one-to-one thing if you're changing. And then Crexont is about similar to Rytari, and it does act a little bit longer, and it has a higher peak, basically because of how the pill is structured, and I'll show you that too. So again, that's a similar idea, but that's also now including the other types of Cinemet. And then this is kind of what the pill doesn't look like this. The pill is filled with these little balls that look like that. So they're kind of covered with kind of a delayed release technology. So the pills can kind of kick in like these little circle things can kind of kick in individually over time. And that's why it kind of lasts longer. Now, in my clinical experience, the difference between at least Rytari and carbidopa and regular Cinemet isn't dramatic for most people. People still need the pills 3 or 4, sometimes even more than that, times a day. But sometimes it can help smooth things out. So if there's a lot of fluctuations, we do try these things. I have not used Crexont yet because it's new and kind of expensive. And the curves are better than the Rytari, but again, it's kind of a cost-benefit thing because, again, Cinemet is a couple of bucks a month, and these are several hundred sometimes. So other things that make levodopa last longer, I'd mentioned entacapone. So that is the one that's in Stalevo. It's also called Comtan. You can get it by itself. It helps stop some of this breakdown so the dopamine doesn't go this way and not work anymore. So that when the dopamine crosses, or the L-dopa crosses your blood-brain barrier, it becomes dopamine, but it can also become this other molecule that doesn't have any dopamine effects. And so the COMT, these entacapone and opicapone, help it not become that. So it makes it last longer, kind of makes the levodopa more effective in that sense. Old medications like the rasagiline, selegiline, Azilect, there's another thing down here, this MAOI, that is another way that dopamine gets broken down, and so those things slow that down. Opicapone is newer than the other ones, but they're all in that same idea. And then there's another, now there's 3 pumps I'm going to talk about. This is called apomorphine, is a very strong dopamine agonist, and has nothing to do with morphine like the pain medication. It's not a pain medication at all. It's a pretty strong dopamine agonist, and they're different than dopamine, so dopamine, is these little dots here. It kind of pushes through. Dopamine agonists tickle these receptors differently and don't have the other effects of the dopamine. It's, again, a nice, smooth infusion and can have the same effects, can help the tremor and the stiffness and the slowness and the imbalance sometimes in Parkinson's disease. There's also an apomorphine, like dissolving patch. I don't know if they make these anymore, but Listerine used to have these little mouth patch things, and they make apomorphine like that too. You kind of put it in the roof of your mouth. You have to be a little careful because this one, like levodopa, can cause like a lot of nausea, and you have to balance it out. So it takes a little bit to get it going, but this is a brand new one too. I have not talked to those reps yet. The downside, so the upside of the dopamine agonists is usually they're smoother onset and offset. They don't cause dyskinesias. They don't overload your dopamine where other cells start to use the dopamine, which is what causes dyskinesia. They just affect the dopamine receptor. However, they can cause like sleep attacks where you fall asleep in your lunch type of a thing. Doesn't happen to everyone, but you have to be careful about that. They can cause kind of OCD types of symptoms. You get really involved in the hobby to the detriment of everything else. You gamble, that type of stuff. So you have to be careful with some of those kind of personality changes that you can see with it. And they can cause nausea too. And again, apomorphine is related to these medications: pramipexole, ropinirole, rotigotine, Mirapex, Requip, Nupro patch. So it's the same type of a medication. It's just a nice, smooth way to get it. Moving on to something completely different. So deep brain stimulation, that brain surgery we do with a little pacemaker device and these wires that go into a deep part of your brain, either the subthalamic nucleus or the globus pallidus interna, kind of depending on what your symptoms are. It's an electrical stimulator that puts out this nice pulse of electricity, and basically what we think it does is it makes your brain ignore the output of those parts of your brain. So there's this big circuit, I think I've shown this to some people before, this direct and indirect pathway where different parts of your brain talk to each other using dopamine signaling, and that is what kind of allows us to plan out our movements. And when it's abnormal, when you don't have enough dopamine, that's what makes it, that's what Parkinson's symptoms are from. And so the DBS kind of deletes one of those nuclei, and that helps the stiffness and slowness and tremor of Parkinson's quite a bit in certain people. It's very similar in efficacy to carbidopa, levodopa. Other than the tremor, it can help the tremor more than Sinemet can. But right now, what happens is we put the stimulator in the operating room, we test it while you're in the operating room, and then we'd have kind of a long programming session a bunch of times because your brain kind of acclimatizes to the stimulation, and we have to balance out your medications a bit too. New devices can listen to your brain now, and there's certain signals in those nuclei that we can hear, we can see. Oh, was that? Sorry, I don't know if that was me or not. Wake up, everybody! Yeah. There's certain signals in the in these nuclei that we can see that we know kind of correlate to when things are not going as well, when there's more slowness, or especially when there's more tremor. And the new DBS devices have the capability, although this isn't fully fleshed out yet, of responding to that, where it turns the stimulation down or off when you don't need it, when those signals or those tremors aren't there, and turns it back on when you do need it. And so it can do this, one, by listening to your brain, so there's certain kind of electrical potentials that we can see. And the other way it can do it is you can wear like sort of like an Apple Watch type of a thing, where it can tell when you're starting to shake, and then the DBS can kind of kick in differently when you're doing that. The whole purpose of that is it makes the programming a little more automatic, and saves the battery a bit too, because it's not on as strongly all the time. Because the battery, initially there's one-time use batteries. They last a few years depending on how much energy you put through them. So if we can turn them off sometimes, they last longer. You don't need another surgery in your chest to replace it. But it's kind of a nice way to like move forward with the programming easier than having to come back in and see me every couple of weeks for a little while. This is the family on Easter. We got 6 kids. My Millie here is in Sound of Music at the Pavilion today at about 2 o'clock. I'm going to go there next. And Gideon is going to be 2 in July, and my oldest is 13 back here. So busy time at home. And so now we're going to talk a little bit about kind of the research that's going on right now, kind of clinical trials things that are happening that are at least relatively close to clinical experience. There's a lot of basic science research going on in Parkinson's too, but how relevant that is to people in the room it's probably not that relevant right now. So we're going to look at stuff that's kind of on the cutting edge that might be coming out fairly soon. And to do that, we do have to talk a little bit about what we think the cause of Parkinson's is, like what happens in Parkinson's, so we can adjust those things to help protect the brain, slow the disease process down. So Lewy bodies, there's Parkinson's disease and then there's Lewy body dementia, and they're not the same thing, but Lewy bodies are made up of this chemical called alpha-synuclein. I abbreviated alpha-syn in here a few times just to be aware of. And they are in your GI tract, they're in your nose, and they're in your brain. And there's kind of an imbalance between where they are, if it looks like Parkinson's disease, or if it starts to have some cognitive effects and hallucination effects that looks more like Lewy body disease. There's debate if they're really different things. It's just where these Lewy bodies are in your brain and your body that causes the disease to look different. There is kind of a body-first hypothesis in Parkinson's, and really more in general regular Parkinson's, and then there's a brain-first hypothesis more in Lewy body dementia, actually. It's getting tight. And so there's some thought that they actually start in your gut or in your nose and move into your brain. So stopping those Lewy bodies from progressing is one of the goals of these upcoming therapies. And this alpha-synuclein is what makes up Lewy bodies. The alpha-synuclein is actually used by your neurons to help regulate neurotransmission. Those chemicals that spit out and cause nerve signaling, alpha-synuclein is involved in that. So we can't just get rid of alpha-synuclein entirely. There's kind of good and bad versions of it. Misformed proteins is what causes the Lewy bodies to build up. So this alpha-synuclein folds the wrong way and then kind of clumps together, and then your body can't really get rid of it very well. And so this is kind of a diagram of that. So this alpha-synuclein clumps up, starts to cause problems, builds up in the cells, and it can be seen in anything that's kind of related to dopamine neurons, which not only is in your brain and your gut, but it's also like moles, melanins, the little dark spots on your skin. Those are related embryologically to dopamine neurons. So there are some alpha-synuclein inclusions in those too. Which is why, I don't know if there is a skin test now for alpha-synuclein to look to see if it's Parkinson's or not. But we don't use it that often because the clinical exam is still better than that. But, and so the therapies that we're going to talk about kind of target alpha-synuclein. And some of them are antibodies, where we give you an antibody that targets that bad protein aggregate. When they misfold and they build up, these antibodies can attack that, and then your body, using its own immune system, can target those antibodies and take them out of your brain. That's what we're doing in Alzheimer's disease right now. It's targeting a different protein, but those are available clinically right now. There's also ways that you can kind of induce your body to make antibodies, which is what vaccines do. So they kind of inject something that sort of looks like alpha-synuclein, it looks like Lewy bodies, and that makes your immune system aware of that being abnormal, and then it can attack it. And there's also ways that you can use small molecules to kind of block that aggregation of the protein. So the antibody effect here, so again, we inject the antibodies. The alpha-synuclein is this kind of red stuff here, and the antibodies attack that, and then these are the alpha-synuclein in your neurons. So the white blood cells in your bloodstream, that's the immune system. In your brain, it's kind of a little different. There's these things called microglia. They can move around in your brain and clean up stuff, and so they get targeted to take these antibodies out. This is a more detailed version of that. And it also, I want to show you that these alpha-synuclein inclusions can actually move from neuron to neuron. That's how they spread, we think. It's not like all these neurons are developing themselves. They actually spread between nerve cells. So there are a few early phase clinical trials, kind of phase 2, so they're determined that they're safe in healthy people, and then they started to give them to people that have Parkinson's to see if they're also safe in Parkinson's, and then phase 3 is the ones that will look at how efficacious it is. So they're moving between phase 2 and phase 3 for some of these. Vaccines, they're early enough that we're not 100% sure how well they get into the body. So normally, if there's a immune target that's inside of a cell, it's hard for other cells to see it. Those microglia, your white blood cells, can't look inside the neuron and see this protein. So that's one of the limitations of the vaccines, but they're still working on that. That's still a possibility. Let's go back here. This is one of the drugs that is an antibody to alpha-synuclein. That does, right now, in a kind of a phase 2.5 trial, show some slowing of disease progression. But they kind of showed that using basically those motor sensors, kind of the Apple Watch thing, to see how much you're moving, how bad the tremor is. It's a little bit weird way to target or to see efficacy, but it is promising. I think that's a good upcoming study. And I've been talking to those guys about bringing that here possibly if things align. One of the issues, though, is, I said that you need alpha-synuclein for nerve transmission, and so you can't get rid of all of it, so these have to target just the aggregate stuff, so they have to be kind of selective, and they don't want to cause more problems than they're worth. There was a paper, 2 years ago, I think now, so in some of these European countries where they have national health records, they can go through huge amounts of data and try to find patterns. And one of the patterns they found was that people that got a tetanus vaccine tended not to develop nearly the significant amount of Parkinson's in the next 5 years. And it's like 10%. It's a big percent. So I think it saved about, I think it was 83% of people developing Parkinson's if you had a tetanus vaccine. And they also thought that it decreased disease progression a little bit too. There's not a good mechanistic understanding of why that happens. And the reason an adult would get a tetanus vaccine is because you stepped on a nail or got a dirty wound. Which usually means you're very active, you're exercising, you're hiking, you're working in construction sites. So people that are very active, people that exercise a lot, people that go hiking, they also develop Parkinson's less, and disease process is slowed. Like we've kind of said about exercise in general, it slows down the disease process, so that might be some of this effect actually. Not that a tetanus vaccine is bad for you. You need a tetanus vaccine if you get a dirty or infected wound. And then there's another way to target alpha-synuclein. So alpha-synuclein, again, it's a protein that your body makes, so there's a gene for it. And there are some genetic versions of Parkinson's that basically make you make a lot more alpha-synuclein. And so we can make selective gene kind of edits or targeting things to block production of alpha-synuclein. It's hard to block the production of that abnormal alpha-synuclein because that happens after this. And I just wanted to mention, this is called, it's called the dogma of biology. So you start with DNA, the stuff that's in your nucleus of your cells and gives you all of your genetic traits. DNA gets copied by this, it's called transcription. It makes RNA, and the RNA goes out into your cells and attaches to proteins, and the proteins create other proteins, the proteins that the genes encode for. These are called ribosomes. And so this mRNA, messenger RNA, does that to kind of get your genetic code into production. And so there's ways to block basically this step with other types of mRNAs, antisense oligonucleotides. And so they splice a gene and they inject it into you. Sometimes that's like a virus that they use to get the gene into your system. It's a safe virus. It just gets the gene in. It doesn't cause any disease. And then you can block the alpha-synuclein, and so you make less alpha-synuclein, less Parkinsonism. Again, this is very early clinical trials because these are in mice that we've created to have something that looks like Parkinson's. They don't have like naturally occurring Parkinson's disease. So it does help mice right now. And to kind of bring this around a little bit, there is some debate in the movement disorders societies whether alpha-synuclein, these Lewy bodies that we see in everybody that has Parkinson's, actually are the problem, or are your cells kind of compensating for a problem? So they're a sign of your cells fighting something off. So there's debate whether, again, like if we get rid of the alpha-synuclein, will that help things or not? Again, the alpha-synuclein is present in everybody that has Parkinson's disease. Genetic causes of Parkinson's have a lot to do with alpha-synuclein, and they can kind of transport between cells. If we inject alpha-synuclein into mice, they develop something that looks like Parkinson's. However, you actually lose a lot of dopamine cells. There's a lot of neurodegeneration that happens before we can detect alpha-synuclein. The cells that are alive in your brainstem have alpha-synuclein in them, have the Lewy bodies. They're still alive. They're not the ones that you've lost already. And again, alpha-synuclein is important for nerve control, so we need it. And there are also people that have alpha-synuclein, like Lewy bodies, all over their brain and don't have Parkinson's. So there's, again, a big debate, but that's why we're doing these clinical trials, to see if getting rid of alpha-synuclein will be helpful. But we don't 100% know that yet. And I guess the other issue here, so again, the alpha-synuclein helps regulate nerve transmission. And the cells that are involved in Parkinson's, in this basal ganglia, that help you plan out your movements, are really old. They're like evolutionarily, they're in like lamprey eels and things. And they're very, very active. They're super fast. They kind of, in a sense, burn out over time. And they're almost, they basically are designed to do that. If we all lived to like 150, our dopamine cells would burn out and everybody would look like they had Parkinson's by design. And so we're trying to kind of push that off with these disease therapies. And people with Parkinson's, that progression is much faster than in the normal population. So again, this is the kind of the crossover between Lewy bodies and cell loss, and they're not 100% crossed over. So there's people that develop Parkinson's that have the nerve loss and have Lewy bodies, and these are genes that are related to Parkinson's, kind of tweak your Parkinson's risk. So again, it's not certain that Lewy bodies cause Parkinson's. The other thing that's new and I get asked about a lot, kind of a different way around here, are stem cells. So the problem in Parkinson's, the cells that make dopamine have died, and so replacing those seems like a good idea. Stem cells that are undifferentiated and become other cells, they have tried in many clinical trials, and they're still currently working on this, to either inject cells that are precursors to dopamine cells or cells that have become dopamine-producing cells already into your brainstem. The only way they can get into your brain is through an injection into your brain. You can't put them in your bloodstream and get them there. And there's multiple ways of doing that, multiple types of stem cells. These kind of mesenchymal stem cells are from a regular person. So you can get stem cells from your fat cells. They can create stem cells from them by kind of genetic modifications and chemical modifications, and then they can develop those into different types of cells. Those kind of become these induced pluripotent stem cells. And then there's embryonic stem cells, which are from fetal embryos, and they can become any type of cell in your body, although they are a different genetics than you, and so they're kind of, in a sense, like a transplant. So those ones you can become kind of immune to, and you can attack those with your immune system. So those aren't actually quite as good for this type of a therapy. There are a lot of clinical trials going on in this. There are ways to buy stem cell therapies. There's companies that do that kind of fat cell thing where they take your cells out, make them into stem cells, and give them back to you. They don't inject them into your brain. They do kind of reduce inflammation. They work for like knee surgery types of stuff. When they inject them into your knee, they can rebuild some cartilage. But again, they don't get into your brain, and they're not FDA approved to do anything, and the reason they're selling them to you directly without insurance coverage is because they're not found scientifically to help in Parkinson's anyway. And so there's this thing, clinicaltrials.gov. It's accessible to everybody. Any clinical trial that's going on gets registered through that. But as I was researching this stuff, I didn't know that the NIH doesn't actually check those things. So companies, like stem cell production companies, can put stuff on the NIH website there. So you have to be a little careful about that. So looking at clinical trials that are based in academic centers is kind of what you want to do. Because there are some stem cell kind of clinical trials that are private companies that aren't like actually going through the FDA processes. Again, this is kind of how the stem cells are made. You take those fibroblasts, kind of the fat cells, your skin cells, you make them into pluripotent stem cells, and you can induce them into making neurons, and then if you inject them into your brain, sometimes we have got them to make dopamine in your brain and have got them to survive. But not only do they have to make dopamine, they have to connect to the right other cells that need the dopamine, and that's the part we haven't quite figured out yet to replace. So that is still a work in progress. So I said that my daughter is in a musical at 2 o'clock. I'm in an opera at 7:30 tonight. The South Dakota Symphony Orchestra is putting on this this opera. Hasn't been produced since 1950. It's a book called Giants in the Earth. Have anybody read Giants in the Earth? It's Norwegian settlers coming here. They talk about going to Sioux Falls to mark their claim. It's a great book, and it's a short opera tonight. So I'll be doing that. Should be fun. If you want to come, I think there's tickets left. And I'm bringing that up because this next slide, so other ways of treating Parkinson's symptoms. It actually involve music. So your gait especially. So in Parkinson's, they have freezing. Those little tiny steps sometimes are kind of your rhythm of your walking gets broken up. And so they have tested kind of auditory feedback mechanisms where they kind of give you a beat to follow or even give you music to follow, and that can help even out your walking. So you kind of step on the beat. It's kind of that self-cued thing, which they do in like big and loud physical therapy too. They kind of give you those cues to step over stuff. And there's multiple ways to do that. You can't just have one cadence of walking all of the time. Sometimes you have to walk faster than others. Sometimes you have to take smaller steps. And so there's kind of AI tools now where you wear these little things on your ankle, and that kind of detects how fast you're trying to walk, and then it sort of produces some sound or some beats, maybe even selects certain music that you can walk to. Again, these are still kind of clinical trials, but those are all things that we can do now, and they do that in some therapy centers. I was looking up kind of music-related therapy stuff, and there is this thing called the vibroacoustic therapy. It's a big chair, big speakers in the chair, but they actually produce kind of subsonic vibrations. So we can hear down to like 20 hertz sometimes. It's a really low bass sound. These are slower than that. And there's some evidence that that can help tremors. I don't know where you can get these off of Amazon. Again, there's hard to do a placebo-controlled clinical trial with these because you can feel these vibrations, so you know they're happening or not. So it's hard to say, we can't do a sham version of these things. But they're very safe, and they might be helpful. This is another thing that I thought was kind of interesting. Similar lines to that music therapy stuff. This is they call these HoloLenses, or HoloLenses, but there's Apple glasses. There's a lot of different versions of these. And in Big and Loud, they kind of tell you to step over a crack type of a thing. Well, this thing projects stuff to step on, stepping on tiles, and so it gives you that visual feedback. And I believe they can program it to walk around stuff. So you can kind of always either produce this in front of you on like looking on the floor, or I believe they could do that too. So because they can actually map out your house using these HoloLenses and kind of show you pathways to take. This is actually the map it makes, so it sees your furniture. And these little red spots are actually where people kind of had the freezing episodes, so you can kind of help work through that. So these things are very safe, and I think can be quite helpful in the future, and I'm sure they don't have to be this big. So right now, what's available, the first part of the talk, these levodopa infusions, kind of extended release versions of levodopa, apomorphine infusions to help smooth out your dopamine kind of dose. And then the future directions, these kind of anti-alpha-synuclein things, stem cells, and then these assisted devices, again, they're not like prime time, you can't buy them on Amazon right now, but you probably will be able to soon. And I think that covers it. Here's an older picture of my family from last year, last time I got a haircut, probably. And now we'll kind of open it up for questions, if anybody has any. Okay.
Doctor, with regards to your what you gave and told us today, my question is, can you repeat that?
Okay, yes. Sorry, I talk a little fast sometimes. I think it's recorded. You can slow it down, too.
And I just wanted to tell everybody here that I have been on the pump, the Duo pump, for 30 days now. Prior to that, I was taking many of the carbidopa-levodopa. I was taking, at the end of my time before I got on this, 16 tablets a day, 3 tablets every 3 hours or whatever that comes out to. And since I have been on this program now, I'm carrying it with me, I have had not one downtime. The downtimes were killing me. They were just horrible. So if anybody has any questions, I'll be here and you can come and I can maybe ask just on the dumb patient side. I don't know all those big words, but thank you.
Where are you sitting at? Okay, right here in the middle, she'll be sitting for later. Larry, you have a question?
We have a question here first. I'm over here.
With the tetanus vaccine or whatever, do they recommend then if you have Parkinson's to get it more frequently than, or just the?
Not right now. That was kind of like this retrospective trial thing. They don't. I have not been recommending getting a tetanus vaccine prophylactically. It's helpful to prevent tetanus if you have those infections, and that's really important to do. But yeah, I don't think it's like.
Because I think they say every 7 to 10 years.
Yes, unless you step on a nail.
Right.
Yes.
Right.
Yeah.
Thank
So that's
you.
still the recommendation.
Thank you.
What kind of reduction have you seen on carbidopa, levodopa after DBS?
So it depends on where in the brain you're putting it. So if you're doing in the subthalamic nucleus, you can usually get rid of a fair bit of it. On average, 50% of people get rid of about 50% of their pills. Some people come off of them completely. Some people, it's hard to come off of them. In the other section of the brain, the globus pallidus interna, the DBS helps out a lot, smoothing things out. It can help with some of the extra wiggly dyskinesia stuff, but it's a little harder for people to come off or down even on their medications.
Does the pump, is that covered by insurance and/or Medicare?
So right now, Duopa is, Vyalev, I was just told this morning, might be. They haven't like fully created their requirements yet, Medicare, and then the insurance companies will follow what Medicare does. So the intestinal gel one is covered. There's certain criteria you have to meet about like off times and things. And I think in the next 6 months we'll know more about the Vyalev.
So in lieu of the time release pill, if you took a half a pill more frequently than you take your 1.5, can you kind of get the same effect?
Yes. So that's the other, like, you can, I have people that take a half pill every, couple hours to kind of smooth it out. You can dissolve Cinemet in something a little acidic, like orange juice, and just sort of like sip on that all day with a similar effect. It's a little harder to titrate because you don't know exactly how much is in there, but that is, it's safe and doable.
I've had a DBS for about 10 years now, Dr. Ritter. My question is, the one you talked about where you can wear a watch and maybe have it, can mine be traded out or no?
So do you have like a rechargeable? Yes, you can trade them out in certain situations. Those things aren't quite prime time yet, but we can update. Some of it is programming updates. Have you had the same chest device that whole time?
No, I had it changed to a rechargeable
Okay.
a while ago.
So some of the rechargeable ones technically have that capability right now, if we would adjust stuff the right way, and the company may put out some of those things. But I've also had people switch off of the rechargeable to do other updates sometimes.
Have you seen any legitimate research into methylene blue?
Oh, there we go. Not really, no. I mean, it's kind of an anti-inflammatory type of a thing, and those can be good. I mean, getting less inflammation is good, but I don't think it necessarily cleans up alpha-synuclein right now.
Is there anything out there that deals with non-movement issues of Parkinson's, such as GI and things like that, other than the typical GI treatments?
There's nothing like for constipation and things. And like GI motility, there's nothing like specific to Parkinson's, no. The dopamine, again, sometimes helps with that, sometimes does not. Sometimes the pills cause some constipation. But it's the stuff, I mean, seeing the GI doctors and kind of monitoring or using their medications, staying ahead of constipation, taking like Miralax kind of every day all the time, and staying ahead of it is helpful. But there isn't like Parkinson's GI medications, no.
Nothing that works on the vagus nerve?
What?
Nothing that works on the vagus nerve?
Well, the medications for the GI system they work on the vagus nerve. They potentiate some of those effects.
I'm not real familiar, but do they have a time release form of carbidopa?
Yeah, kind of. So there's the regular Cinemet, there's this Cinemet CR with like continuous release or extended release. They, again, on average, they work a little bit longer during your daytime, although in my experience, they're also more affected by your diet. They're a little less like reliably 100 milligrams every time because, I mean, they take longer to kick in. And that's one of the reasons they last longer. So there are, and I do use them sometimes in specific situations. Sometimes the levodopa, like the regular Cinemet, causes too much nausea, and the CR versions, because they kick in a little slower, don't cause that as much. But the going dose for something like a Cinemet CR is still 2 or 3 times a day at the beginning.
Okay, we have one last question.
How do we get a copy of your slides?
I sent them in last night, so I think they'll be uploaded at some point to the website, I believe. And these are recorded talks, right?
Yes, and we'll help you get those uploaded to our website.
And I believe is it on YouTube, so you can turn down or up the speed depending on what you need.
Yes, that's true.
Otherwise, thank you very much. Thanks for having me.